Thank you very much for those challenges and throwing that out. I think we'll throw it open to discussion from the floor and see what one question comes to my mind immediately, which is, I'm sorry I had to step out for a couple of moments there, but when you talk about, say, people who are doing really just prescription refills, that would strike me as kind of a recipe for burnout for the individual doing it. If that's sort of all you're doing, even if you're doing it in your living room, that's pretty dull stuff. How do you work around that?
And so that's where I think that culture piece becomes so important, because that can turn out to be the case. Now, the way that you can diversify that work, so you can introduce other tasks to the process, so getting rid of just doing things beyond prescription refill requests. But honestly, the people that are driven to that type of role, in our experience, that's the type of work that they don't want to be in patient care for whatever reason. And so allowing them to work from home, diversifying that skill set, that becomes an important piece to ensure that doesn't become the case.
I think one of the challenges we're faced with often is, as you know, I've been working on this stuff for a long time, when to do an ALT, when is that recommended? Do we or don't we do ongoing monitoring of lipids now? What is the current blood pressure guideline 2 months ago, and what will it be 3 months from now? What's the A1C target based on evolving evidence? And that's one of the problems that has led to some stagnation on our current revision of our UW Health medication refill protocol, because, as you say, as important as it is, we've got centralized groups working on these are the guidelines that the organization endorses, which then carry forward to the refill protocols, but you can't retrain all the people that are doing these refill protocols routinely on a regular basis to implement in real time the newest evidence-based suggestions. So that's one area of concern. The second, not a concern, but just implementation challenge. The second is your 10 times efficiency increases is probably far greater if we can do tomorrow's work today. So for example, when you react to a refill for one particular medication and you see that of the 10 medications that are on a person's medication list, 8 or 9 of them are refilled at various different times over the last 12 months. How do you convince people, whoever's doing this work, that in fact we should probably reset the clock on all 10 of those refills today so that you don't get 10 refill requests over the next 12 months when each of these come due at different times. And when's the appropriate time to do that? An asynchronous process, as that refill request comes in, or at the time the person comes in for their physical, whatever. So these are things that I'm personally struggling with, and I'm curious what your perspectives are on those couple issues.
Yeah. So I mean, those are all those are all interesting points. So the first one on the guideline side, so that's where we've seen the best practices. So from what I understand, that you guys are spread out. So you guys are decentralized right now in that approach. That's one of the biggest advantages, that management of those people and those protocols, particularly at this stage where there isn't a technology or a major technology component, because then because you're right, these protocols, these evidence-based guidelines change over time, and what's going to happen is that if you have to retrain hundreds of individuals, like how does that ever turn into a scalable process? Versus the central team, where these can be, on a regular basis, can be retrained, much easier to train 5 people, 10 people that are doing this particular task. The second point, which is very valid, and I didn't touch on this, was this whole concept of when you're thinking about these tasks, how do you move them from reactive tasks to proactive tasks, right? And this is something that so much of healthcare today is driven on a reactive model. So what I mean by that is that we're just waiting for work to come in, and then we're acting on it, rather than using these different points to say, hey, how do we get proactive? How do we get ahead of this so that we don't run into issues? The challenge, I'd be happy to talk some of the specifics on the refill side. The challenge is, in many cases, the system isn't put in place to support that proactive model, right? So very practically speaking, and when you try to tee up, we've seen many customers that have tried to tee up those results or those refill requests, and then the pharmacies reject them or they lose them, right? And then so the patient tries to go back and you didn't do, it didn't actually help the situation, right? And so in terms of best practices that we've seen, that's where if you're going to go down that path, working very closely with the pharmacies that you're going to be engaging with to make this possible is oftentimes a challenge. But there's no silver bullet to that, but we always, through this process, have to be thinking about, is there an opportunity to get proactive? And that's as we've started to think about like our future, some of the things that we're working on in the future, very much in that mindset. How do we get ahead of it?
And I'm going to start with a comment, hopefully turn it into a question.
Yeah.
Obviously that's all important to us as physicians, but you touched on the fact that health systems really have to see dollars to be able to get there. So one of the things I've seen in smaller scale are business models that are predicated on the value proposition, risk-based payment, have really gone to a small scale, self-grown electronic health records because they have the flexibility to form the team around them and to adapt. Most of them are the monolithic programs that we have out there, Epic, Cerner. So how does something that you've developed that really is a practice enhancement, that they really don't have a platform yet, will they ever have a platform yet to try to improve practice? And the willingness for them to interact and cooperate and let it plug in to ways that then do enhance practice is one of our biggest obstacles as health systems, because we as practitioners have very little voice at changing that, yet we know the pinch point, we know the pain point. We can create the team, but if there isn't things that support the team that are fundamental, you can't get there. Yet these other smaller systems are doing these things. And for the proactivity, Iora Healthcare is an example. Just look them up online. It's a business model based on the value proposition. They're growing their own and they're proactive, and I visited them. I know it's real. So, any comment on how do we change the current state? Because we're really in a stalemate now.
Yeah. Well, and that's what. I would throw that. So I would throw that back at you real quick and say, well, why do you think that is? Why are we at a stalemate right now?
I think it's I would say part of it's the lack of the willingness to innovate in health systems. Part of it's compliance, and part of it's a cost structure, because you've already invested a lot in that monolithic platform.
Yep, sure.
So how do you invest on top of that?
And so one of the fundamental premises of the company that we've built is that what will happen, it's a question of when, is that these systems will turn into platforms, right? And what I mean by that is that so if you look at every other industry, I like to characterize what's happened is that in the early days of an industry's formation, the proprietary systems are really important. And the reason, at least in my estimation, is that if I'm a CIO and I'm buying an EMR, I'm spending $500 million on an electronic medical record system rollout, I need to be sure that that thing's going to work, right? I need to be sure that it's not going to fall on its face and we're going to have a big disaster. And so the way that vendor ensures that it works is that they control everything, right? So there's no third party, because the third parties introduce risk for me that the system might not work. And so, but by controlling everything, by saying I have one unified system, I can ensure that it works. Now, what's happening though is that we're at this interesting point. A lot of people call this the innovator's dilemma. Yeah, we're past that point, sure. So where now, but what happens over time is that it was one thing just to get an electronic medical record system up and say, hey, we've got data. Now you ask the question, well, what do you do with it, right? And as particularly right now in healthcare, what makes it so compelling, we're going through this giant transition in the business model of healthcare. And so as those health systems get more complex and their needs grow, then what happens is they have more needs of their vendors, right? And they can't rely on a single vendor to solve all their problems. And so what happens is that all these different systems begin to pop up that say, like, oh, we'll do this for you, we'll do this for you, we'll do this for you. And then the underlying system is the platform. So this happened, probably the best example is Salesforce. So Salesforce is a CRM, which is kind of like it's like the electronic medical record equivalent for salespeople. And it's where they store all their data. And so Salesforce said, we're going to open up this whole platform and we're going to allow others to build on top of it. And there's a whole bunch of great solutions that have been built to accomplish that. Now, there's as you said, we're at this very interesting point in the industry where this is starting to shift, right? Even 5 years ago when we started this, it was completely unknown to have a build on top of the electronic medical records. But it is changing, and you're seeing the government side is pushing it. You're starting to see MUs including things like APIs, which APIs are basically just ways for people engineers to tap into like different things in the electronic medical record systems. And so the change in my mind is inevitable. It's how do we accelerate that change?
It's the acceleration of the innovation.
Yeah, because then once you guys don't even, in my world, I see all the companies that would love to like build on top to make your life easier, but they can't even figure out how to get into the darn thing in the first place, right? And so as an industry, we need to continue to push that forward. And honestly, in many ways, I think it starts with like you guys, the physicians, because while you may not feel like as an individual you have a significant push, as a collective, you absolutely do. If I've seen anything in my time, is that if the physicians want something, they can get it, and that's what all of the electronic medical record vendors today are very driven by their customer demand. And so at the end of the day, if you guys push for it, that's one avenue that's going to push it forward. But I think as an industry, we need to figure out how to accelerate that pace.
And it seems like we have to get away from worrying a lot at this point about what's the standard as physicians, but get to how do we drive innovation.
Mm-hmm. Yeah. I've always had some concern, and you talk about centralization being a little challenging, that when we get into larger and larger groups, that then you begin to have issues of communication, kind of creating small cultures. Somebody years ago did some research, and it turned out the ideal functional size of a physician group was something like 4 to 6 docs. Mm-hmm. And beyond that, issues of governance and sort of coordination and all superseded any economies of scale. Mm-hmm. And even things like prescription refills, I've been nervous over the idea of centralizing because, Brian here set up a very good system for us, but in one way there's a minor downside. It's so disconnect from the patient, because sometimes if I had to refill the atorvastatin or something, that was a chance to say, how's your husband doing with his dementia, or, there's I love the INR stuff. I'm never calling patients back about INRs, but that's also kind of disconnected me a little bit from the patient. So there's that kind of flip side to, or even if the person does call about the INR, they don't know the patient. They don't know that her husband has dementia. Rather than having somebody call the patient who really knows them and kind of knows their family situation, how do you balance that? So
I would challenge you on that and say, is that the most meaningful interaction that you could have with that particular patient? And so when I think about that, so I say, like, you could have all this work as the physician on your plate, right? So we could give you refills, INRs, we could give you the whole kit and caboodle, and you would have time. So sure, you could call it 5 of those patients, and then, because those are the refills that you have to do that day. But is that really the best work for you to be doing? Like, if you were to take the giant step back, right? What particular refill came in that day, is that really the patient that you should be calling at the end of the day? Or is there probably another patient that might not be getting the refill because they're not even compliant on their medication, right? That actually would better deserve, or it'd be more appropriate to make a phone call to them. So I'm not discounting the fact that it is valuable. It's the question of, at the end of the day, is it the most valuable, the highest value add thing that you as a physician can do? Well, or I may know the individual patient, say, well, this one I need a call back because I know there are other issues, and that the other 6, to heck with them now, just put them on autopilot and let them go. Yeah. So it's that issue of knowing kind of which patient needs the refill and is there an issue or not. And so the vision, how we think about what the future looks like, is that today, so we think a lot of the work falls on the physician and their staff today, and we need to figure out, particularly for the easy patients, so the everything's good, everything's either they don't have a chronic condition or they do and it's well controlled. We need to get that 80% of that work off of their plate and automate it. Literally everything is automated, and so the world of the future is not where anyone has to do refill requests, is that they're completely automated, right? So electronic systems, checking all the things that need to be checked, and in theory, they go back to the pharmacy. That's not the world we live in today, but it's where we would drive towards. So 80% of the work is handled in that way. Then like 10, 15% is handled by the team. So as these patients get uncontrolled, but they're not at the point where they're extremely uncontrolled, the team can handle those. So I can set up a nurse visit, or I can set up a telephonic visit, or a virtual visit. But then 5% of the work today is really what falls on the physicians, where you guys, as the physicians, the world that we want to drive towards is where you are seeing the patients that really, really need your attention. So the highly uncontrolled patients, patients with multiple comorbidities, but where you're spending an hour of time with them per visit, not 15, 12 minutes, but an hour of time to really sit down and solve their problems and help them get there, because that's what is the most valuable for you as a physician. But then everything else behind the scenes is automated or taken care of by the team. So that's what it's about, doing the most effective thing.
One thing I don't think we do a very good job of as clinicians, at least I'll say for myself, is share the knowledge that we know about the patient with the rest of the clinical team. And so, I do OB in my clinical practice, and in Epic there's the sticky note functionality where it's not an official part of the record, but it's clearly a very effective and appropriate way to communicate. Next time this patient comes in, ask about this, or next time this person comes in, you got to make sure you do a follow-up ultrasound. And I could totally see every time one chart comes up, how do you know in that medical records room or the EHR, what it is that you need to know that gives you the type of knowledge that John has about that patient, which makes him uncomfortable to let somebody else do the work because they don't know in real time what they need to know that's most relevant for that person. So, for example, controlled substances refills are very different than non-controlled. And for somebody who works at, I have a patient who's a cinematographer and gets tomorrow I'm supposed to be in California, and I'm supposed to have my refill on Monday, so yes, I'm calling for an early refill. The front desk only knows that person as a chronically calling in requesting for early refills, not knowing the social context behind completely up to speed, completely professional, completely respectable, yet I should communicate back to them, just so you know, every time they call in, stop giving them this, sort of attitude, us giving the attitude that, stop calling us for early requests, don't you know you're supposed to give us 48 hours, etc. So how do we clue in the team with the knowledge that we know? And I think that's more the art of the practice behind the 4 tenets or the 4 principles that you're outlining there. So I guess challenge your practices that you work with to do that, and I'm going to be challenged myself to think about how to do that more effectively as well.
Yeah, no, that's absolutely a great point. And that's some of the things that we've started. So my take is today that, do you guys really have time to do that today? All that would be awesome, right? Is that possible today? And that's where I think a lot of this stuff, at the end of the day, every physician that I come across is just, is fighting to stay above water. And so we need to lower that water level. We need to get some of this work off their plate. And then we can start to introduce some of these things that it'd be great to do if we had the time to do it. And so that's what our goal is the low-hanging fruit, let's get that work away, and then take that on, because I think it's absolutely the right answer. But at the end of the day, it's much harder turning it into practice, right? Yeah.
So Jonathan, we know as engineers that technology always introduces stuff. We're going to call it stuff. And stuff sometimes is safety issues. Stuff is sometimes not really understanding some of the qualitative or anticipation things that I think a couple of people have talked about. So where in your process does that come through? That we know automation and so on is great. Stuff is just going to happen. So I'm putting my safety hat also. Putting my safety hat in your talk, and I was trying to figure out, because safety very often falls into this step, and safety sometimes comes contrary to efficiency. So what does the process of handling stuff that happens with technology is integrated in your?
Yeah. So it's a great point, and that's where so when we think about, so I'll unpack that a couple different ways. So the first thing is that the stuff that comes up, right? And the stuff is related to the technology and to the workflow. Is I don't think there's any way to get rid of the stuff, right? So even even when you have a perfectly humming system, there's still going to be things that come up that are going to disrupt the practice in whatever way, right? Now, the way that I think about that is that we have to figure out how to minimize that. And we have to figure out how do we understand the trade-offs that we're making and understand what our goals are, efficiency, quality, whatever they might be, and then live with those variations. Now, in my experience, you get far more of that stuff that comes up when you're not doing a lot of this other stuff. So by putting in these standard processes, you're now putting in place these best practices. And over time, that stuff will go away because you're going to figure out what is the best way to get this work done. The quality side, at least in my mind, falls into the same category, which is that if you're not standardizing right now, it's very common for me to go into a health system and say, okay, let's take clinic ABC. Tell me how you do this task. Like, let's pick a task. And this one is going to say, oh, we do it this way. This one we do it this way, different. This one we do it this way, completely different. And so from a quality perspective, I would much rather get everyone pointed in the same direction and then figure out what that direction is, rather than having everyone going in all sorts of different directions. And as a health system, if I'm responsible for the quality across a health system, it worries me more if there's a whole bunch of different things that are getting done rather than I know exactly what's getting done. But I think it's an evolving process. So it's not something, the mistake here is that you put this in place and then you let it stagnate, right? But you have to learn over time and you have to build up and adapt to the stuff that's coming in and figure out what the best way is to handle it.
I would just add too that I think sometimes we have a perception that the technology has introduced the stuff, when in fact the stuff existed all along, but putting the technology on top of it has uncovered the stuff that existed. And so I think that and when you talk about the clinic A, B, C, I mean that's why the implementations are so hard, as you said, that the step 1, 2, 3 has had to come before step 4, but implementations of EHRs have been step 4, and then you have to go back and do 1, 2, and 3 in order to make it work for the system. And I mean, that's what all of us are doing all of the time, is taking on what's the next task that has been uncovered as broken with this implementation, and now going back and trying to write that process that was variable all along.
Yep, and I see that time and time again too, is that so as you go through, even going through all this stuff, or all these different steps, you uncover all sorts of things that exactly, right? And and then technology also has so let me, a good example. So you put in place an automated system. So let's say you put in place an automated system to look at the patient's problem lists, identify diabetics, and automate a reach out to them to get them to come back in for an office visit or an A1C, right? Then you uncover that we haven't been documenting these problem lists properly. And so now we're automating a system. We're putting in place a system to automate something, the garbage in, garbage out, right? And so now not only you've uncovered it, but you've actually accentuated it. So that introduces new problems which needs to get solved for. But that is very true.
And I also just, the more and more we talk about provider burnout and, vis-a-vis the work that needs to be done from, so much of it seems to be that it's, all of this documentation that we need to do, all of these things that we need to do in the EHR, but then like John, you make a comment of, but I want to make the phone call to talk about the dementia. So, it's, honestly, I don't know what is it that we think is going to ultimately make us happy again in our profession, because we say, honestly, it's, well, I don't want to do the refill because that's not me functioning to the top of my license and it seems like busy work at the end of the day, but I want to make a phone call and have that conversation. So I don't know, I honestly think that we as providers too need to figure out what is it that we are striving for that is going to give us that joy again. And I don't know that we can expect that we aren't going to have some work at night. I don't know that there is a profession out there anymore that is a well-paid profession that you're not doing some after after business hours kind of work. But I mean, I don't know what the right answer is, but I think there's some soul searching that we have to do too to figure out what it is that provides that joy in practice.
Well, the hour is upon us. And I think, though, that's a wonderful transition, and I would ask you, it's a wonderful to leave us with the question, maybe make it for a great workshop at the iPractice meeting, about really defining those tensions. I think that would be a very interesting workshop to do, so we'll sign you up for that. And Jonathan, thank you very much for taking the time to come. There's more food and coffee. I have to go out and make medical errors at my clinic. But other people can certainly stay.